Welcome to AZEN's Journal Club, episode 57. I am Dr. Z, here with KC, and today we're doing something a little different. Instead of dissecting one landmark trial, we're stepping back to look at a whole question that is whipsawed back and forth. Does low-dose colchicine, the cheap old gout drug, actually prevent cardiovascular events in people with coronary disease? This is a story that runs through several trials and lands on a set of 2025 meta-analyses. KC, start us at the beginning. Why would a gout drug be in a cardiology conversation at all?
Because atherosclerosis is not just about cholesterol, it is also an inflammatory disease. The plaques that rupture and cause heart attacks are inflamed. So the idea was, if we can damp down that inflammation, maybe we can prevent events. The proof of concept came from a trial using an expensive injectable antibody that targeted inflammation and did reduce events. But that drug was costly and complicated. Colchicine, by contrast, is generic, oral, and cheap, and it has anti-inflammatory effects. So it became the practical candidate.
And the early trials were genuinely encouraging. Walk us through the two that built the case.
The first is Colchicine. It enrolled patients soon after myocardial infarction and gave them low-dose colchicine, 0.5 milligram daily, or placebo. It found a reduction in ischemic cardiovascular events, with a hazard ratio around 0.77. The second is Low-DO-CO-2, which studied patients with chronic, stable coronary disease rather than a recent heart attack. That one looked even better, with a hazard ratio around 0.69. Two trials, two different populations, both positive.
And those results had real-world consequences. On the strength of them, a low-dose colchicine product got United States Food and Drug Administration approval in 2023 specifically for cardiovascular risk reduction, and the guidelines added a recommendation. So by 2023, the momentum was clearly behind colchicine. And then, KC, the plot twisted.
It did.
In 2024, we got Clear Synergy, also called Oasis 9. This was big, more than 7,000 patients after myocardial infarction, designed to be a definitive answer. And it was completely neutral. Colchicine did not reduce the composite of cardiovascular death, heart attack, stroke, or ischemia-driven revascularization. The hazard ratio was essentially 0.99, and the p-value was around 0.93. Basically a flat line.
And I want to dwell on this, because this is the fact most likely to get conveniently dropped from an enthusiastic summary. The single largest, most recent, well-conducted trial in exactly the post-heart attack population where Colchicine had been positive found nothing. Zero signal. When a big, rigorous trial contradicts earlier, smaller ones, intellectual honesty demands we take it seriously rather than explain it away.
So that is the tension the 2025 meta-analyses had to resolve. They pooled all of these trials together, the positive Colchicine and Low-DO-CO-2 and the neutral Clear Synergy, plus others, to ask what the totality of evidence says.
And what did the pooled picture show?
When you add that large neutral trial to the earlier positive ones, the overall estimate moves toward the null, but it does not completely disappear. The meta-analyses, including one in the European Heart Journal, found a modest reduction in some composite cardiovascular endpoints, roughly a relative risk around 0.88. But, and this is critical, no reduction in all-cause mortality and no reduction in cardiovascular mortality. The benefit, such as it is in non-fatal events like heart attack and revascularization.
No survival benefit. And there is a cost side to this ledger too.
Yes.
There was a consistent signal of more gastrointestinal side effects, with a relative risk around 1.35, mostly diarrhea and abdominal symptoms. That is a common reason people actually stop taking it. So the honest summary is a small reduction in non-fatal events, no mortality benefit, and a real tolerability cost.
So how do the guidelines square all of this? Because I think the guideline language here is actually a model of appropriate restraint.
The guidelines give colchicine only a weak recommendation, Class 2B. That means it may be considered as an optional add-on in selected patients on top of the standard foundation, but it is not a routine, must-do therapy. The foundation comes first: high-intensity statin, antiplatelet therapy, blood pressure and diabetes control, and lifestyle.
That framing is exactly right, and it is where we as hospitalists should land. Colchicine is an optional adjunct, not a replacement for the basics, and certainly not a miracle. So practically, KC, what does that mean at the bedside?
A few things. If a patient is already on colchicine for their heart, tolerating it well, and having recurrent events despite good secondary prevention, there is a reasonable rationale to continue it. Starting it fresh is a shared, optional decision. And you have to respect its safety profile. Warn about the gastrointestinal effects, avoid it in significant kidney or liver impairment, and watch for drug interactions, particularly with strong inhibitors of the CYP3A4 and P-glycoprotein pathways and with statins, where the combination can raise the risk of muscle toxicity.
And the interpretive discipline, which is really the theme of this whole episode. The temptation is to cite the 2 positive trials, declare victory, and start everyone on colchicine. The corrective is to remember clear synergy, the biggest and newest trial, which was neutral, and to remember that the pooled benefit is modest, confined to non-fatal endpoints, with no mortality gain and more side effects.
So neither dismiss it nor oversell it.
Precisely. The defensible, guideline-consistent position is that low-dose colchicine is a reasonable optional adjunct in selected secondary prevention patients, graded weekly, that reduces some non-fatal events at the cost of gastrointestinal intolerance, with no proven effect on survival. That is a less exciting headline than colchicine prevents heart attacks, but it is the accurate one. As always, verify against the current guideline and product labeling, and individualize. Thanks, KC. We will see everyone next time on ASIN's Journal Club.